I don't think the rationale for cyclin-dependent kinase inhibitors in CLL really needs much elaboration. It's a very appealing target in any number of malignancies, CLL included. And our group has pretty extensive experience, first with flavopuridol or alvocidib, and more recently dinaciclib, a second-generation agent. And much of the clinical development of these agents was initially inhibited by poor PK and PK parameters, which were overcome with pharmacokinetically derived dosing schedules in the case of flavopuridol, but have also been hampered in large extent because of hyperacute tumor lysis, which, as we'll see, is a problem that can be managed and allow the drugs to be given in a safe and efficacious manner. So if we look just back at the initial experience with flavopuridol, this is summarizing data from a phase 2 study that was conducted at OSU. And you can see that when the drug was given in the ultimate administration schedule, it had a really favorable response rate of 53%, including among patients with genetically high-risk CLL. But of course, hyperacute tumor lysis is just one of the problems, and flavopuridol also induces a cytokine release syndrome driven by IL-6, which can be abrogated by co-administration of dexamethasone, but somewhat limited the long-term administration potential of flavopuridol. Many patients found cumulative fatigue to be at least treatment limiting, if not dose limiting. So dinaciclib presented a second generation and more appealing, more pharmacokinetically appealing agent, since it has no active metabolites, had favorable PK parameters with respect to protein binding, and also had a much more favorable therapeutic index while still hitting all of the CDKs, which appeared to be important for the clinical efficacy of flavopuridol. In vitro studies suggested that a CLL cell viability was impaired with dinaciclib in a way that was more potent at lower concentrations than the flavopuridol forerunner. And it also appeared to spare T cells, which is an important consideration, particularly in refractory CLL patients where T cell immunity is already impaired in large extent. So I'll just summarize here results of a phase 1 study that was led by my colleague Joe Flynn and was presented in its final form at ASH this past December. And in this study, primary endpoints of which were the usual safety and tolerability endpoints of a phase 1 study. The patients who had relapsed in refractory CLL were eligible if they had white counts below 200, again, trying to limit the potential for hyperacute tumor lysis. Retained organ function per usual parameters and good performance status was also required. The study followed a 3+3 cohort design, although there were some additional safety cohorts that were added to the study once a maximally tolerated dose was established to try to improve rates of tumor lysis, as we'll see. The drug is given as a 2-hour infusion on a weekly basis for 3 weeks out of 4. And the very first dose of treatment, and in some cases subsequent doses during the first cycle of therapy, were administered in hospital with aggressive monitoring for electrolyte disturbances, hydration, and interventions in the event of hyperkalemia. So the group of patients that were ultimately accrued to the trial, there were 52, and as you can see down at the bottom of the screen, the majority of them were high-risk CLL patients as defined by cytogenetic abnormalities. Many of them had bulky disease. In fact, the majority, 85%, had lymph nodes greater than 5 centimeters, and more than 50% had, or very nearly 50%, had a deletion of chromosome 17p. Because of our experience with flavopuridol, because of its success in managing bulky fludarabine refractory disease and cytogenetically high-risk disease, that was a group of patients that were potentially overrepresented in the sample, which makes the results I'll show you even more impressive. If you can see, the majority of patients had also received prior treatment with, at that point, the usual suspects, fludarabine and rituximab. A much smaller number had received prior alemtuzumab, and since this study began accruing before bendamustine was actually approved for relapsed CLL, only a minority of patients had received prior bendamustine therapy. I'll just show here the dose-limiting toxicities by cohort. You can see there was one case of sepsis at the 7 milligram per meter squared dose, but ultimately the most significant toxicity occurring was tumor lysis requiring dialysis. It occurred once among patients treated at 14 milligrams per meter squared as a fixed dose. As a result, an additional 2 cohorts of patients were accrued with stepped-up dosing beginning first at 10, escalated to 14 milligrams per meter squared, and a subsequent cohort of patients beginning at the dose of 7 milligrams escalated weekly to 14 milligrams per meter squared and continued at that dose thereafter. When we got to the 17 milligram per meter squared dose, it became clear that efficacy was not substantially improved, and there was a case of tumor lysis requiring dialysis. Summarized here are the toxicities across all grades. In general, the drug is reasonably well tolerated. Neutropenia is reported, but infection was actually a relatively rare event. There were transient elevations of transaminases that were mostly low-grade and reversible by the subsequent week's administration. Tumor lysis, grades 3 and above, occurred in 8 patients for 15% of the total group, although most of those patients could be managed medically without need for hemodialysis, and I'll give a little more detail on that. The patients completed a median of 5 cycles, but there were very few patients that discontinued secondary to adverse events, only 3, and 22 of the 52 patients completed greater than 6 cycles, and there were 4 patients who were able to persist in therapy beyond a year of administration. With respect to the tumor lysis cases, they are summarized here. The ones in red are the patients where tumor lysis resulted in hemodialysis. So the first one was at the dose of 14 milligrams per meter squared. Subsequent dose reduction allowed the patient to continue on study. The subsequent cases occurred, one at the dose of 17 milligrams per meter squared, and only one of the 13 patients treated with stepwise intrapatient dose escalation 7, 10, 14 required dose escalation. This was a patient who had very bulky, rapidly proliferative CLL, and he experienced a second episode of tumor lysis despite a repeat of the initial dose of 7 milligrams per meter squared, and actually came off study for safety reasons primarily. This is a completely unreadable slide from your vantage point, but the point here is that responses were actually observed at every dose that was tested. Here in tabular form, that is perhaps a little easier to read, you can see that the overall response rate in this group of very refractory patients was 54%, although the majority of the doses occurred the majority of responses occurred at doses of 14 milligrams per meter squared and above. This is just a representative case example of a patient who was treated who had a really bulky disease, who after completing 7 cycles of therapy had a greater than 50% reduction of his lymph node burden with very manageable toxicity. If we look at the durability of response, it's actually quite reasonable. The majority of responding patients were able to maintain their response beyond a year of follow-up, and that was true regardless of deletion 17p status, again suggesting the unique efficacy of this drug in patients with high genomic risk CLL. So if we were to summarize at least our concluding thoughts on our dinaciclib experience in the phase 1, it is a highly efficacious drug, perhaps less impressive now in a world of 85% response rates, but a very respectable response rate, with about 63 of the 35 patients treated at the recommended phase 2 dose achieving a response. And this is regardless of underlying genetic risk features. The adverse events are manageable. I think tumor lysis is somewhat problematic. We think we may have established a strategy for managing that. And overall, as compared to flavopiridol, this is a drug that other than it's being somewhat cumbersome for parenteral administration, is very feasible for maintenance administration. On the basis of the phase 1 experience, we designed a phase 2 study where dinaciclib was given after initiating ofatumumab at the standard dose and schedule beginning 1 month before, to see if we could both improve the response rates that we had observed, but primarily to decrease the risk for hyperacute tumor lysis. The schema for that study is demonstrated here. Again, the ofatumumab is given on a very standard schedule per package label administration schedule and dose, and that was given for 1 month prior to initiating dinaciclib at the recommended phase 2 dose and schedule beginning in cycle 2. You can just see the doses there. We have finally completed accrual to this study. I think we will have completed accrual to the study within the next 72 hours, if all goes well, and hope to report the initial results at ASH this year. I will tell you that in the 36 patients, 2B37, hopefully not a single patient has experienced hyperacute tumor lysis. Biochemical tumor lysis has actually been relatively uncommon, and no patients have required hemodialysis for what appears to be an equally efficacious regimen. Now, dinaciclib has a relatively uncertain future despite our very certain interest, and a Merck-sponsored phase 3 study comparing ofatumumab to dinaciclib was discontinued last year, and the future development of the drug for hematologic indications, CLL in particular, remain uncertain. But it is our fervent hope that this drug will be resurrected as a potential agent to combine with some of the other emerging agents because of non-overlapping toxicity, as well as some unique properties in the highest risk group of patients who are relapsing with single agent therapy.